for each mother-baby dyad affected by perinatal depression and anxiety could be reduced to $5,000 per family with universal standardized screening. Given this context, it is shocking that the Canadian Task Force on Preventive Healthcare currently recommends against universal standardized screening for perinatal depression. This recommendation contradicts screening recommendations within Canada as well as worldwide, in the US, the UK, and Australia. We at the BC Reproductive Mental Health Program set the standard of care for British Columbia through clinical practice guidelines, resources, and interdisciplinary education. We're a national leader in perinatal mental health care, providing over 5,000 direct patient care visits per year and indirect care for countless patients through a rapid consultation service to BC primary care providers. As determined by the Reproductive Mental Health Program, the standard of care in BC includes universal standardized screening for perinatal depression. In contrast, the Canadian Task Force recommends that perinatal depression screening occur as part of usual care. This means that only patients flagged by their primary care provider will receive additional attention. This is simply not enough. A study in Alberta in 2021 documented that in usual care, approximately 2/3 of cases of perinatal depression were missed. This study estimated that 2,000 cases of postpartum depression could have been detected with universal standardized screening. Usual care places the burden of advocating for their mental health on Canadian women. We know that our healthcare system is strained, and the reality is, under usual care conditions, it's the patients that need to bring perinatal depression to the attention of healthcare providers. What's more, usual care is inequitable care. Research has demonstrated that when perinatal depression screening is left to the discretion of the healthcare provider, racialized patients are less likely to get screened. White women are more likely to have their concerns taken seriously, and women with socioeconomic privilege have the greatest capacity to advocate for their own care. This perpetuates health inequalities and further marginalizes Canada's most vulnerable. You might think that we just don't like the conclusions that the task force reached, but it's more than that. Their conclusions are not justified. The systematic review on which the guideline was based identified a single randomized controlled trial, or RCT, which found that participants who had universal standardized screening had improved maternal mental health outcomes at 6 months postpartum. Further, the patient values and preferences studies conducted by the Canadian Task Force highlighted that participants felt that the potential benefits of screening outweighed the potential risks. Participants characterized potential harms of screening as trivial. Our perspective aligns with the patients in this study who felt that, quote, risks of overdiagnosis or its resulting treatment were not considered critical in comparison with failure to diagnose depression. In summary, the task force prioritized concerns about speculative harms over documented benefits, the perspectives of patients, and the opinions of experts. We need to take the burden off Canadian women. Universal standardized screening promotes equitable access for all Canadians to have a mentally healthy pregnancy and postpartum. We need a Canadian Task Force guideline that prioritizes preventive health care. Thank you.
Thank you very much, Dr. Hipman. Next, we're going to go to Dr. Montroy with the Quebec Alliance for Perinatal Mental Health. Welcome to the committee. You have the floor for the next 5 minutes.
So I am an associate professor at McGill University in the Department of Educational and Counseling Psychology, as well as an associate member of the Departments of Pediatrics and Psychiatry. I'm also a scientist at the Research Institute at the McGill University Health Center. As such, I bring together sort of the perinatal mental health expertise to the early childhood development, and this is what I'm going to advocate for today. To sort of add on to what my colleague here mentioned, the perinatal period is defined as the gestational period between pregnancy and the 12 months postpartum. We know that perinatal mental health disorders such as depression and anxiety are amongst the most common complications of childbirth, affecting as much as 20% of pregnant and postpartum individuals. The rates of postpartum depression have doubled since COVID-19 pandemic, and this is a source that's been provided by Inspiring Healthy Futures with the contribution of Health Canada and Public Health Canada, which is estimating that the incidence of mental health issues among both women have increased, women and men actually have increased by more than 10%. So these statistics are reported to affect an even greater number of women marginalized and underrepresented in the populations, such as the IPOC women, who are disproportionately affected by mental health issues and are most often missed in these studies that we're reporting because we're not specifically targeting these populations. As such, it's creating, it's questioning the generalizability of the findings that we are often reporting. So more than 350,000 individuals become pregnant in Canada every year, which suggests that up to 105,000 Canadians may experience perinatal anxiety and mood disorders, making it the most common pregnancy complication. Pregnancy complications don't just have implications during pregnancy, such as, for example, gestational hypertension, preeclampsia, gestational diabetes, which have received recognitions for their predictive role in the incidence of more chronic disease later on in women's life. This is not the case, however, for mental health during that same critical period of women's health. As it was mentioned, maternal suicide is a leading cause of maternal death in high-income countries, while maternal depression and anxiety are associated with an increased risk of preterm birth, low birth weight, child social, emotional, and behavioral difficulties, and this is where my child expertise comes in, and also known to basically have a lifelong effect into adolescence and be associated with mental health issues in teenagers and adulthood. So some cost analyses that have been conducted in the United States, the United Kingdom, and Australia, countries very comparable to the one that we are living in, Canada, highlight the significant economic impact of untreated, and I mentioned untreated, perinatal mood and anxiety disorders in Canada. Thus, many experts working in the area, such as us here today, do question the lack of early detection and appropriate treatment of maternal depression and anxiety, as well as its consideration as a public health priority. Unlike other gestational conditions affecting the pregnant person, mental health issues remain the most underdiagnosed. According to Diabetes Canada, to just give a little representation or an equivalent, gestational diabetes affects one in 10 women. We said that mental health issues affect about 20% of women. Yet 1 in every 632 births would result in a baby with potentially complications such as Down syndrome. And this, again, is according to Health Canada data. Now, this data alone has sufficed over the years to understand the need to conduct and maintain a systematic nuclear translucency gestational diabetes screening as part of the routine prenatal care. Yet, despite what we know of the incidence of mental health issue and the fact that it affects both the woman's health and the child in terms of intergenerational transmission, we do not have the same type of screening when it comes to mental health issues during pregnancy. It's not part of our prenatal care, unlike some of the countries that I mentioned before that are developed countries such as ours. So, that being said, given the high prevalence and adverse consequences of perinatal mood and anxiety disorders, several countries now have recommended, as has been mentioned before and will be mentioned again, the need for routine screening of prenatal anxiety and depression and other mental health issues during the course of pregnancy. The failure to identify these risk factors of adverse perinatal mental health outcomes can have negative consequences on the mother, as I've mentioned, but also the child. Using an existing evidence-based model that is stemming out of the London School of Economics, we've been able to conduct this same type of economic impact calculator with the Montreal Antenatal Wellbeing Study that I represent. The economic impact tool was necessary to determine the economic cost of perinatal health mood disorders and also enable us to be able to make these estimations throughout every province. We are now upscaling this tool to include a cost effectiveness of interventions and referral interventions to the Canadian context. The first phase of our economic impact calculator has produced an estimate that a lack of routine screening in Canada will lead to about $6.7 billion per year in Canada. The cost of perinatal mental health illnesses in Canada is associated to about $46,000 per births, per deliveries, and about 70% of these are accountable to the child. The child will basically go on to develop adverse effects and outcomes such as poor cognitive functioning, which are basically also impacting their future development. So the evidence speaks for itself. The benefit to the mother or pregnant person can be achieved via preventative care during the prenatal phase. Not only can this present as a benefit to the woman during pregnancy, but could also play a critical role in early detection and prevention of other postpartum disease, as I've mentioned, such as breast cancer, cervical cancer, cardiovascular disease, diabetes, and osteoporosis. Using a precision health framework.
Dr. Montroy, if I can get you to wrap it up.
Yes.
You'll have lots of time to
Yes.
expand during questions, but if you could just bring it to a close. Thank you.
Absolutely. So honestly, we've always been able to address that it's a benefit to the woman during the pregnancy, but also postpartum. And as a benefit to the child, targeting perinatal mental health issues is optimal for its development and contributes to society from a human capital standpoint. Thank you.
Thank you very much, Dr. Montroy. Colleagues, we are having some technical difficulties with the connection to our online participants. So we're going to suspend to get those resolved before we invite them to present their statements. So the meeting is suspended for hopefully just a short few minutes. We have some highly trained professionals here in the IT support team for committees, and it appears that we're back in business. I hope I didn't jinx it. Dr. Van Lieshout, welcome to the committee. You have the floor for the next 5 minutes. Oh, no. We can't hear you, Doctor.
Is he muted? He's not.
I put on a new headphone. Is this better?
Let's.
Can you hear me now?
Yeah. Okay, we're going to redo a sound check. I can hear you, but the trick is whether the interpreters can hear you well enough to do the simultaneous translation.
Just wanted to ask you to move the boom of your mic up to between your nose and your mouth. I think, and just like we did at the start, could you just give us quickly introduce yourself, and we'll get a thumbs up.
Sure. I'm Dr. Ryan Van Lieshout, Canada Research Chair in Perinatal Mental Health and the Albert Einstein Irving Zucker Chair in Neuroscience at McMaster. Did that suffice, Patrick? I'm sorry.
I'm just waiting for some feedback. Sorry about that.
Okay. I'm sorry about that.
So the feedback we're getting now is if you could move the mic away from your mouth a little bit. Apparently, it's causing some popping.
Okay. So I moved it away, and I'll speak again. Hopefully, this is just to you, Patrick, instead of in front of the entire committee. But if it is,
we're good to go. Thank you very much. Sorry about that.
Okay.
no.
Thank you very much. Thanks for your patience. Dr. Van Lieshout, you have the floor.
Thank you again. Good afternoon. I'm Dr. Ryan Van Lieshout, Canada Research Chair in Perinatal Mental Health and the Albert Einstein Irving Zucker Chair in Neuroscience at McMaster University. I'm a psychiatrist, a clinician scientist who works with individuals struggling with their mental health during pregnancy and the first postpartum year, and whose research focuses on developing scalable psychotherapies for those with perinatal mental health problems. We also aim to optimize the delivery of these treatments to maximize their impact on offspring brain development. The primary goal of my work is to disrupt the intergenerational transmission of psychiatric problems from parents to their children. My clinical expertise led to my invitation to co-author Canada's National Practice Guidelines for the treatment of perinatal psychiatric problems and Public Health Ontario's Perinatal Mental Health Toolkit. Throughout my career, I've seen the devastating effects that mental health problems occurring during pregnancy and the postpartum period have on children and families, and have committed my work to reducing their impact. As the other experts have suggested today, perinatal mental health problems affect up to 1 in 5 women, but the disproportionate effects of the COVID-19 pandemic on mothers led these rates to increase to 1 in 3. As previously mentioned, each case of postpartum depression alone is associated with costs of up to $150,000 over the lifespan, 2/3 of which is attributable to offspring. Even though effective treatments can help both mothers and their children, as few as 1 in 10 pregnant and postpartum persons are able to access evidence-based care in this country. There are many barriers to the receipt of timely perinatal mental health care in Canada. One of the most significant of these is the current absence of coordinated care pathways that identify sufferers and match the right person to the right treatment at the right time. Second, since most individuals with perinatal mental health problems will respond to psychotherapy or talking therapies and or medications, another significant challenge is the relatively limited knowledge possessed by frontline physicians about the safety of these medications during pregnancy and lactation. Finally, the profound lack of access to evidence-based psychotherapies, driven primarily by a lack of healthcare providers trained to provide them, prevents us from meeting our goal of becoming the best country in the world to raise a child. However, there are many reasons for hope. A group of Canadian clinician scientists, of which Dr. Vigaud and I are members, are working with the Canadian Network for Mood and Anxiety Treatments to prepare national practice guidelines for perinatal mental health problems, which can be used to help educate frontline providers and guide the creation and application of Canadian-specific care pathways. These structured care pathways, integrated systems that involve the detection of mental health problems, direct patients to the right resources at the right time, and provide treatment and follow-up, need to be tailored for the Canadian context and implemented. Once these pathways are created, they will enable us to use evidence-based psychotherapies developed and tested right here in Canada to optimize treatment. However, there exists a substantial shortage of trained mental health care professionals required to deliver these interventions. To address this, our group has developed and tested several effective, scalable psychotherapeutic interventions that can be delivered by a variety of individuals, including public health nurses with no previous psychiatric training, or even individuals who have recovered from psychiatric problems themselves, also known as recovered peers. These treatments can serve as both initial and more intensive steps in care models. For example, our one-day cognitive behavioral therapy-based workshop from postpartum depression can effectively treat up to 30 individuals at a time and be delivered online or in person by public health nurses or even recovered peers. Our 9-week group cognitive behavioral therapy intervention has also proven effective, and its delivery has already been successfully task-shifted to recovered peers and public health nurses with limited to no previous psychiatric training. These have already been scaled and are in use in Canada, Europe, and the United States. As Dr. Montroy pointed out, we know that when mothers get these treatments, they not only help them, but their offspring as well. Perinatal mental disorders are among the most common adverse childhood experiences. But research by our group and others has showed that treating mothers with postpartum depression leads to clinically meaningful improvements in mother-infant relationships, infant brain development and emotion regulatory capacity, and even the mental health of the older children in the home. This is in keeping with research from around the world that suggests that for every dollar invested in early childhood interventions, society reaps a $7 return. Perinatal mental health problems in Canada can be prevented, detected, and treated, and we already have the know-how to support mothers and disrupt the intergenerational transmission of mental disorders in families. The federal government can help by working together with experts to create Canadian-specific care pathways, scale the perinatal mental health workforce to meet the needs of mothers, and work together with the provinces to implement these systems. Such developments will enable our Canadian-made discoveries to improve the health and lives of all Canadians. Thank you.
Thank you, Dr. Van Lieshout. And finally, Dr. Simone Vigaud from the University of Toronto and the Women's College Hospital. Welcome to the committee. You have the floor.
Thank you to the chair and the committee for inviting me to present today on the topic of the mental health of women. Merci beaucoup de m'avoir invité. By way of introduction, as you've heard, I'm a psychiatrist. I'm the head of the Department of Psychiatry at Women's College Hospital in Toronto, where I also hold a research chair in women's mental health research. I'm a full professor of psychiatry in the Temerty Faculty of Medicine, the University of Toronto. For the past 15 years, my clinical practice and my research has focused on women's mental health. So what I wanted to talk to you today about is how and why I believe that the mental health of women is a major public health issue for you to consider. From menarche, the time that people get their periods, to menopause, women are 2 to 3 times more likely to develop common mental health problems, such as depression and anxiety, than their male counterparts. Mental health problems in women, of course, affect their well-being and productivity. Because women are often caregivers of all others in their sphere, when they are unwell, this can also negatively impact their children and families. When I talk to my students about this, when I talk to partners in the community about this, I usually say there are issues of mental health that are unique to women. You've heard about some of those today, including pregnancy, of course. And then there are issues that disproportionately or differently affect women. So biologically, there are unique considerations. For example, mood problems that fluctuate with the menstrual cycle might require different treatments or different medication regimens. We've heard quite a bit about pregnancy already today. Would add that treatment decisions in pregnancy and when someone's breastfeeding require us to think about the potential for impact on a baby. Also, even the way that women absorb and metabolize medications, they do this more slowly than men. So a dose of a medication, for example, that was established for an often larger or heavier man in the clinical trials might lead to toxic side effects. On the issues that disproportionately affect women's mental health, one of the biggest is physical, emotional, sexual abuse and assault, which is much more common in girls and women. You probably know that trauma changes the brain. It increases the risk for depression, anxiety, and post-traumatic stress disorder substantially. In fact, we now know that more than 50% of women with mental illness report having experienced prior trauma. Women are also at elevated risk of poverty, of isolation after immigration, stress due to caregiving, among other factors, which can not only increase their risk for illness, but also increase the barriers to them receiving care. So I thought I would tell you a little bit about how our Department of Psychiatry at the University of Toronto at Women's College Hospital has addressed this. And Dr. Van Lieshout works in a very similar program at McMaster University. But we are one of University of Toronto's main academic health sciences centers, and we've really taken these considerations to heart. So our department comprises the following clinical programming. 1, a reproductive life stages program for women who experience mental illness related to the menstrual cycle, around the time of pregnancy, as you've heard is very important today, and around the perimenopause. Then number 2, we have programs that cater to women from at-risk populations, including immigrants, refugees, Indigenous women, and women experiencing addiction. And then number 3, we have a trauma therapy program for women who've experienced emotional, physical, and sexual trauma, and now are experiencing complications of mental illness. Within these programs, because we're a university hospital center, we're dedicated to expanding knowledge beyond our walls via research and education. So we study causes of illness, such as our Canada-wide study of postpartum depression genetics. We identify novel treatments as well as how best to use existing ones. So, for example, we're using a non-invasive neurostimulation to treat depression in pregnancy for women who are worried about using antidepressant medications. And we just received funding from the Canadian Institutes of Health research to look at ADHD medications in pregnancy, because this is dramatically increasing in use among women. We also, as you've heard about today, develop and test innovative models of care to improve access, including not only in the pregnancy period, but also to expand access to trauma-focused therapies. And finally, we train clinical providers across all disciplines, so not just psychiatrists, but also social workers, psychologists, midwives, and other multiple areas of medicine that are related to ours, such as endocrinologists and gynecologists, so that people who are new providers and those who've been many years in practice can help to better treat the 50% of their patients that are women. But as you've heard from my colleagues today, while we're making excellent progress, the goal of having all women with mental illness in Canada receive timely, effective mental health care is not yet quite achieved. So I believe that some great impact on a national level would be to invest in the following concrete, actionable priorities in women's mental health. First, I would recommend a mental health awareness campaign about women's mental health to empower women to know what they can and should expect about their mental health and from their treatment. Second, really championing the education and training opportunities in women's mental health, such as those we have developed, Dr. Van Lieshout's team has developed, and others have developed across the country. And three, increase the targeted research opportunities to both improve the experience of care for these women with mental illness today and to develop prevention and cures for the women of the future. Given the large number of Canadian women affected by mental illness, even small gains in meeting the mental health needs of women across their lifespan has the potential to lead to a large positive impact on the health of all people in our communities. Merci and thank you.
Thank you, Dr. Vigod. We're now going to begin with rounds of questions, starting with the Conservatives. Ms. Vecchio, please, for 6 minutes.
Thank you very much, and thank you to all of the different witnesses today for bringing your professional opinions and your work to this. I'm going to just start off very simply because we know that 1 in 5 Canadians don't have a family physician. So I believe this would be probably one of the biggest challenges. And so I see that most of you are in the academics fields, but perhaps you can share with me what you would know about this, because if you don't have a family doctor, then when you're pregnant, what do you do? So it's important to have these task force guidelines, but if there's not somebody monitoring them all the time, what do we do in that situation? And I just want to pass it over to Katrina, to Ms. Dr. Hittman, if you could just share with me some of your thoughts on that.
Yeah, that is a really important issue. In British Columbia, you can also directly access midwifery care, and I think the perinatal period represents a little bit of a unique moment in a woman's life where I think there's a greater chance that she would be able to connect with a family doctor. I've heard sort of anecdotal stories of people being able to get a family doctor when they're pregnant. And so, I think that's somewhat optimistic in being able to have that continuous care. But I'd also suggest that it could be beneficial to consider more of the self-screening and self-care options that exist. For example, I know of research in Alberta of a study that has basically instituted a program that's online that does empowers women to do screening for themselves, and then it can also connect them with online self-help, like self-care, self-directed cognitive behavioral therapy, and that kind of thing. So you can kind of let them do it.
I really appreciate that. And hearing the testimony today, I've always had the thought when we talk about perinatal care and we talk about postpartum depression, I've always thought only about hormones. But many of you have talked about the environment as well, and we know that trauma adds to the environment. So when we're looking at the hormones, actually, I'm going to pass this one over to actually Dr. Van Lieshout, because you had talked about the medications. And I think as a mom of 4, I know that, or mom of 5 had 4, I think that's something that's very important to me, is going through depression, going through anything, watching what you're eating, watching what you're drinking so that you ensure that your child is safe. Can you share with me what they're currently using when it comes to helping maybe with a hormonal or what things are safe?
That's a great question. Thank you for asking. As I mentioned, we're currently preparing the latest version of under Dr. Vigod's leadership, the clinical practice guidelines for the treatment of a range of mental health problems during pregnancy and the postpartum period. And when we reviewed the literature carefully again, it appears that there's a relative lack of knowledge among a lot of professionals about the relative risks and benefits. People will often hear horror stories about things like this or read things online, but the vast majority of the medicines used to treat depression and anxiety have a relatively good safety record. And it's not that every person who has a mental health problem should be prescribed a medication, but it's really important that those who are already taking it and their healthcare providers are aware of the relative benefits and risks of these treatments, and that people who are thinking about taking them don't just automatically turn them down because of things that they're uncertain about, or that their healthcare providers are uncertain about. So it's just we're so happy to have this opportunity to update these guidelines and disseminate this information to all of those front care providers that are doing such excellent work with the women and mothers, pregnant persons, and birthing parents that we work with.
Thanks so much. I heard many of you speak also about peer-to-peer, a variety of different things that we can do. And that counseling piece, I think, is so, so important. If you're looking across Canada, what is the, for somebody to try to get into for that counseling, perhaps if they have had a child, what type of timeframes would they be waiting to either have a peer-to-peer, maybe it's a counseling session with a group, or it might be a one-on-one? Can you tell me what the timeframes and timelines are for somebody to access a physician on this issue? Actually, Katrina, and then followed by Tina.
Okay, great. Sure. So I can speak in British Columbia, for example. There's a Pacific Postpartum Support Society that has support provided by phone and by text message. So a person who is experiencing postpartum depression can connect with a peer that is on the other end of the line, and that's the hours are not 24/7, but it's very accessible. And then in terms of the actual sort of more formal counseling, that would take. It depends on how much money you have to access it privately. Basically, if you can afford it, then you can get it almost right away. But if you need to go through the public system, then that can take 6 months, 8 months. Depends. Yeah.
So I think that the lack of guidelines, the Canadian guidelines, when it comes to just screening and providing care, has led to, across Quebec, for example, very different types of programs being delivered based on the institution. So, for example, you'll have the St. Justin Hospital, where I happen to work, where they have sort of a step care approach. So, because we have, for example, a chief of OBGYN over there that very much is attuned to what the reality that we've depicted today. And therefore, they have, for example, for all women being seen at that institution, there is a screening and referral process in place. And so therefore, there's also, but you were talking about self-care. So there will be, for example, a package called Grand Ours, which is really intended for psychoeducation, for example, connecting women with various resources across the province, one of which the Quebec Alliance on Perinatal Mental Health, also another well-known regroupement des ressources périnatales du Québec under the guidance of Marie-Claude Dufour. So therefore, there's already initiatives there to allow women to be able to be connected. If you look at other institutions, there will not be that. So therefore, I think that also points to the fact that even when there's the best of intentions to provide care, because there's no clear guidelines in terms of what to do, there's even discrepancies not just among provinces, but even within provinces themselves and institutions.
Thank you, Dr. Montreuil. Suite, c'est le tour de Madame Brière pour 6 minutes, s'il vous plaît.
Thank you, Mr. Chair, and for witnesses to be with us this afternoon. Je vais adresser mes questions au Dr. Montreuil.
I'll put my questions to Dr. Montreuil. First of all, very simple question. When we talk about perinatality, what's the period covered? Well, as I mentioned at the outset, it's as of the conception, as of pregnancy, up to 12 months postpartum, so the first year of life of the child. Thank you. Would you like to continue with your opening remarks, or were you able to round them off? Well, I do have certain results that I can share. For example, in Quebec, we're going to be launching a pilot project from the Canadian Research Institutes, and that will give online interventions to really help with emotional regulation and to debunk the myths around these changes, biological and physiological changes, which are part of the prenatal monitoring, but also to talk about the psychological side of things, which is often overlooked. So we work with peri-aides, and they say in the postpartum Bible, if you like, there is a section. We've got 300 or 400 pages that talk about the baby and its care. And there's perhaps just 2 or 3 pages that talk about a postpartum mental health. So the point that I was wanting to make earlier, when it comes to follow up with the baby after immediate postpartum, there's a protocol to check that the baby is going to move around safely in the home. And we've also got a protocol, the shaken baby syndrome. And I do agree that it's good to have these routine exercises. But when we talk potentially about violence vis-a-vis the baby, the precursor, of course, to that is the mental health of the parents. So when we're checking a baby seat, for example, or why do we not check the potential risk of the mum or dad actually causing a trauma to the baby? Why do we not actually check up on the precursor, first of all, to see how am I behaving in this new situation, going through this new transition? So the transition to parenthood isn't the same for everyone. People have different experiences. That is what we need to bear in mind. And for most people, we have to ask right away about the question of access and then availability. Availability versus accessibility, as we say in English. There are lots of resources that are available, but now we have to see how we can integrate all of these, embed them within our care, our healthcare communities. And even if we said to the BIPOC community that these resources are available, then it begs the question, how can we not get access to these? There's a question of stigmatization. So pregnancy is an opportunity, as Katrina said, where we can create this type of link with the health system so that afterwards we're able to better prevent these disorders within the family. Thank you very much. You've actually answered several of my questions and opened up a door to others. So do you think then that in the prenatal courses, perhaps there needs to be some training or a section dealing with this? Yes, absolutely. We've also got another pilot project which has been funded by the Fondation des Étoiles in Quebec and also by CHU, the Hospital University in Saint-Justine, with the ECHO program, which is teletraining online. We mentioned today the fact that one of the reasons why people don't feel that they're able to carry out screening are saying it's because treatment as usual already covers mental health aspects. But we know that is not the case. Studies have shown this. And professionals are well equipped to do several things, but they don't feel well equipped to screen for these mental health issues. So with this program, just like other programs across Canada, it's possible to have training, refresher courses with our various health professionals, such as midwives, doctors, physicians, social workers, nurses. And once people are well equipped, then they feel that they can carry out this type of screening. So with this pilot project, we're showing that if we actually fund a training, that will offer up other possibilities to actually enrich our healthcare system with the people who are already there. Then, of course, there's another issue. We need to hire more people to do this or reorganize our resources. But at least there are already things that we can do by setting up and establishing this type of guideline. So you think that interdisciplinary approaches are key to this? Yes, that's a key. For example, we worked with the Quebec Alliance on Perinatal Mental Health back in 2022. We were able to present that recently amongst Canadian decision makers. It was organised by the Desmarques Foundation. And there we questioned several target persons who would have an impact on mental health and an impact on women's health in Quebec in general. And we identified three major obstacles. And one of these is the question of integration. The resources are already there, but how do we connect these up? How do we join the dots? Sometimes there's duplication of efforts and there's people working in silos. So we have to, first of all, recognize the fact that perinatal mental health has to be tackled within the public healthcare system. And then secondly, we have to see how we can reorganize this. And we've seen this with the Desmarques Foundation. The event really revealed that there are several players within the community who play a key role in all this, and they could be better embedded and integrated within the healthcare system. And that would alleviate the burden, if you like, which can be created as a result of this transition. So we need to assess what's already available and see how we can tie all of that together and bring all of these different elements together so that it becomes feasible and practical to do so. Thank you very much to both of you. And now, Ms. Berube for 6 minutes, please. Thank you very much, Chair, and thank you to the witnesses for being here today, and thank you also for your significant expertise. I've got a question for Dr. Montreuil. Earlier, you referred to marginalised women. What are the consequences which we see perhaps more during childbirth and before and after giving birth? I talked about preeclampsia and other types of inflammatory diagnoses which disproportionately affect women in these marginalised populations. So sometimes we look at these statistics and we say, oh, it's not that many compared to other statistics, but we have to also consider that this is an underrepresentation. We're all researchers here, so we know that when we ask for participation, in general, we try to target people who are underrepresented, but it's always an obstacle, a barrier. There's also a question of trust. What are our motives behind this when we're carrying out that type of study? So many of our studies, unless we specifically target these people, we are not actually able to represent these populations. So that's why it's very important to work with communities and community partners, because they already have these established links, for example, with the indigenous populations or also with certain black women populations. They're already integrated into community resources, so it'd be really advantageous if we could work more with these community organisations. They already have created this trust, and then we could have higher representativity. So that's a simple example I can share with you. It's certainly something to consider. And I think that the task force is really looking at this, but perhaps we need to fund more research that could target these women populations in particular. And these are implementation science projects. It costs a great deal when we do that type of project because we have to mobilise not just a community of researchers and practitioners who are used to carrying out research, but we have to work with people who've got this lived experience in the community environment. They're not experts. So we need to have funds so that we can carry out correct studies on this rather than just having observational studies which are limited, really, in terms of the actual positions that they can allow us to develop. Now, another question for you, Dr. Montreuil. Now, I come to Abitibi, and we're considered to be a remote region, and we know that there are many women that go through a postpartum situation or pregnancy loss, and we know that all of this exists in Saint-Justine, but it's complicated out in the regions in more remote areas. So often these women do not necessarily have the right tools to get through this. So what's your vision as a researcher in terms of observing of this in Quebec? First of all, we've worked with women through the Alliance, and we've seen that there's recognition that there's a great deal of work still to be done in terms of postpartum. There was one woman recently where we recorded a podcast, and in those discussions she said postpartum follow-up really doesn't exist. My child had 10 meetings postpartum, and at each meeting with the pediatrician, I was dying inside. That's what she said. I would have loved to have been asked how I was getting on, but I never received that question. And when I thought about putting the question myself, I thought, no, I'll be seen as someone who doesn't care about my baby because I'm putting the focus on me instead of on the baby. So it's not an easy question to tackle as well. I've already worked with people in different regions, such as up in Gaspésie, and there's a great deal to be done when it comes to the first tier, the first level. The research of Dr. Lieshout has shown that when we give them access, something that's recognised with a stamp from the province, and there is something that's coming out in Quebec in a similar vein. I'm involved in that. So the idea is to provide a service and put a stamp of approval on this from the ministry. And every time we come from the follow-up, we look and tell them what's accessible if you're going through difficulties, for example, during your pregnancy. And then we can combine that with the ECHO program, because there's something I haven't mentioned. We're carrying out other studies, and we give them another lever. We give them access to internet, but also follow up with a coach, a nurse, or a social worker. For people where Tier 1 is not sufficient, it's too basic, they need a bit more. and then perhaps we can refer people to psychiatry. But by covering with step 1 and step 2, we can probably resolve this a great deal. I see it, we work a great deal with tier 3, with tier 1 and tier 2. We can deal about 70% of the referrals that are sent to psychiatry. So then we're left with 30% of people who really need to see a psychiatrist. And that will then alleviate the burden on the overall the system. So as I said, it's a question of rejigging this, reorganizing the system, because everything's flooding into tier 3. Could we not actually mobilize these people and draw them in at tier 1 and tier 2? And that would then alleviate the demand on the healthcare system, as well as meeting the needs of the more isolated remote communities, as you've mentioned. So you've got 20 seconds left, if you wish. Well, a quick question, please, to Dr. Hipman. What are the consequences on mental health of a pregnancy, loss, or infertility? What's the effect? If you could give a brief answer, please.
Well, it can be very difficult, and it can be, I don't know exact rates of depression, but they're high, and infertility can be incredibly stressful and can lead to anxiety, depression, and then loss. There can be difficult to tease apart, a postpartum grief reaction versus, postpartum depression. But it's important not to dismiss postpartum depression, assuming that it is grief, and not have good support for people in that context too.
Thank you, Dr. Hipman. Merci, Madame Berube. Next, Ms. Idlout, please, for 6 minutes.
Thank you, Chair. It's a pleasure to be here, and thank you to all the witnesses for all your expert testimony. I think I'm going to be asking most of my questions to Katrina Hipman. The reason I kind of struggle to ask general questions is each of the witnesses are from very different institutions and different parts of Canada, but I was interested to hear about the standardized screening that you recommend. But before I get to that kind of questioning, I wanted to ask specifically about Indigenous women. How long has it been known, would you say, that Indigenous women are more vulnerable to mental health issues?
Yeah, I feel like it's something that we need to continue to expand, our attention in that area. I do see that there is more research happening and more attention to support, mental health for the Indigenous community. But we're still really early days, and there's such a problem with the lack of trust, as has been mentioned, and as I'm sure you're all aware, in terms of actually being able to have someone feel comfortable to self-identify as Indigenous. That, there's a program now, like at BC Women's Hospital, like we have a system in place to connect, Indigenous patients with an Indigenous peer support worker and an elder, and but they need to feel comfortable to identify as being Indigenous. And given what we know about racism in the healthcare system and all of the, discrimination and negative, harmful impacts that can have, it's understandable if Indigenous people don't feel comfortable sharing that they are Indigenous or coming to the healthcare system at all. So it's a big issue, and but we are working to try to find ways to build that trust with the community and try to find a way to also meet their mental health care needs in the perinatal period.
At the risk of asking you to generalize, which I'm not, what are some of the issues, I guess? What are some of the realities? What are some of the realities that make Indigenous women more vulnerable to mental health issues?
Yeah, well, just one thing is sort of the top of my mind is the, histories of trauma that so many, intergenerationally as well as personally, pregnancy can be a time when trauma can really come to the surface in ways that people maybe don't always expect. But you kind of grapple with identity shifts, and it connects to your, ancestors and, generations going forward. And so it's a really sensitive time, and I think it's inadequately appreciated and supported. It's wonderful to hear from Dr. Vigot about the stream of support for trauma-informed care in their programs, but I don't think that that's a strong element of our healthcare system, generally speaking, in getting that support for people to go through pregnancy and have attention and care to the trauma that may be triggered and that they may need to process.
So in terms of moving towards when you're making recommendations about standardizing screening, how would you make sure that that kind of standardization incorporates the need to reflect and understand what Indigenous women may have gone through, so that we are ensuring the move towards recognizing what some of those, how we catch those struggles and make sure that they're being included in some form of standardized screening.
Absolutely, and it's such an important issue to think about how there's a history of child removals from Indigenous families, and which is just so tragic, and that has been seen as part of the perinatal healthcare system as well, in manifesting in a practice that was known as birth alerts for Indigenous women, that after the birth they would be seen by a child and family development worker, and there was a higher risk that their child would be removed. And now that practice has ended, but relatively recently, like I think 2019, and so there's still that history and fear, very valid fear, that if I'm coming into the system with pregnancy as an Indigenous person, is my child going to be taken away from me? And add on top of that, if you're asking me if I am experiencing depression or some other mental illness, that's ammunition for you to take away my child. Like, I can understand that being a really sensitive problem, and something that I think we need to have more tailored screening approaches for Indigenous communities, so that they are not feeling threatened, and so that we're then embedding that within a tailored system where they can then receive support that is culturally sensitive and trauma-informed.
Thank you, Dr. Hippman. Thank you, Ms. Idlout. Next, Ms. Roberts, please, for 5 minutes.
Thank you very much, Mr. Chair, and thank you to the witnesses. So I'm going to go back to a question that my colleague Karen brought up, and that's the family doctors and the lack of them. So last Wednesday, there was an announcement made in Ontario. I'm from Ontario, by the way. I think we talked about that. And the announcement was that the Ontario government is going to provide $9 million to York University to build a medical, you heard it? Yeah? A medical school right next door to Cortellucci Hospital specifically for family physicians. So it was quite interesting, because if I look at the stats, in Ontario, 2.3 million do not have family doctors. And in 2026, 4 million people will be without family doctors. So that's 1 in 4 people. That's just Ontario. Here's the kicker, though. The school will not be built and finished for occupancy until 2028. And then it's another, I think it's 4 years. I mean, we're so far behind with family doctors. I know the Conservatives have a really good plan with our Blue Seal plan to bring doctors in, because listening to you, it's important that we identify these issues so that we can protect women. In 2018, maternal deaths, 8.3 deaths per 100,000. And in the past 10 years, it looks like it's doubled. So it is something that is really important if we're going to stand up for women. I don't know. I guess I'm just not normal because I lost 5 kids, and I think what helped me was my faith and my family and the support system I had around me that helped me get through it. You know, they finally, when I did get pregnant, they made me stay in bed. I think that was worse than anything else because I'm not the type of person that likes to sit still. So do you think that those support systems, because of COVID, and I know you mentioned COVID, that those support systems just fell by the wayside? And I'll leave it open to anyone that would like to speak to that. Thank you.
I can start a little bit.
Oh, great. Thank you.
I have, if you like. So thank you for that. I mean, as a psychiatrist, I have a lot of colleagues who are family physicians, and many of whom refer to me. And, the thing about having a family physician, especially when we're thinking about women, is a family physician follows you throughout your whole lifetime, right? So they know you. They know if something isn't your baseline, if something is off. They're sort of watching things. And actually, if we're talking about that 20% or more women across Canada have a mental health issue, that's kind of like saying that all the cardiologists would manage every high blood pressure. The truth is, it's the family physicians who are like the first line of defense for mental health issues, and it's the family practices like the teams where that sort of first basic counseling starts. One thing that was really interesting, we did a model of care for perinatal mental health where we had women they didn't need to go through their family doctors to come in, but when they first came in, we did that stepped care that we talked about. So we sent them for peer support. We got them, psychological treatments in the community that they didn't even need to see a doctor for. But then a small proportion might have actually needed medications, or they might have actually needed something more. And what we were able to do was somebody like me who knows about all the drugs and pregnancy and everything, I was able to, through just some quick phone calls with the family doctors, figure out what the patients needed, and patients trust their family doctors. And out of the 50 people we put through our initial pilot, only 2 of them had to eventually come and see me.
That's awesome.
Right? And so it just underscores, and family doctors know when there's something with their patient that isn't quite right? Almost like a parent knows with their child when something's not quite right. So, the importance of primary care as the backbone and as the infrastructure of our health system, I think can't be understated.
So I guess the other thing is that one of the other things that we have to do is we have to ensure that when our own Canadian citizens leave to, get their education elsewhere, when they come back, that we have them ready to be family doctors, and I think we need to improve that. And I really believe that our Blue Seal program will help that, and I agree with you. The family doctor probably knows you better than anyone else, and that's the only way we're going to prevent these type of situations and deaths from happening. So I'm glad you agree with that.
Thank you, Ms. Roberts.
I wasn't finished.
I'm afraid you are.
Oh.
Mr. Joe Harry, please, for 5 minutes.
Thank you, Mr. Chair, and thank you to all the witnesses for your testimony today. Dr. Vigot, I'm going to direct most of my questions to you. As you know, in May of 2023, the Government of